My journey in wishing to bring about improvements in informed consent for patients began 25 years ago when my son Sam was born with cerebral palsy following a very traumatic birth. Although it's a very tragic story, it's one that I'm always willing to share if it will help in the understanding and the importance of patient choice and informed consent, or as I prefer to call it, valid patient consent. I would like to emphasise that this wasn't about blaming a particular doctor. This was about me wanting to understand what had happened to me, why it happened to me, and to ensure with every fibre of my being that this never happened to another patient again. There are times in life when you have to stand up for what you believe in, even if you're standing alone. But I wasn't alone. Thankfully, I had the support of my family, who were all medical. My mother was a GP, my father was a hospital doctor, and my sister was then a junior doctor in anaesthetics. Next slide, please. I was diagnosed with type 1 diabetes when I was a young child, and I attended the diabetic clinic for many, many years growing up. When I was much older, I was married, I was 24 years old. I discovered I was pregnant, and I was delighted. And I was delighted to discover that the same diabetes staff that I knew very well and had looked after me for a long time would be looking after me throughout my pregnancy in a joint diabetic obstetric clinic. I was keen for them to continue my care, and I had a lot of confidence in them. As a type 1 diabetic, my pregnancy was considered high risk, and I attended a joint diabetic obstetric clinic fortnightly. I was reviewed there by both the diabetic and obstetric consultant, and ultrasounds were conducted fortnightly to monitor my baby's growth. From 32 weeks onwards, I could see from the centile chart that my baby was large and continuing to gain weight rapidly, despite meticulous diabetic control, reaching the 95th centile, and this worried me. During this period, I raised my concerns repeatedly to my consultant obstetrician, particularly about my ability to deliver this baby vaginally, given the fetal size and my short height of only being 5 foot. I was always met with reassurances and that I didn't need to worry and that she was monitoring the situation closely. At my 36-week appointment, she told me that she was cancelling my last scan booked in at 38 weeks because she felt that the baby's size was fueling my anxiety. I was told instead I would be brought in for induction at 38 plus 5 weeks, but I felt that my questions had still not been addressed and no other options for delivery were discussed with me. After induction, I entered into a lengthy labour requiring augmentation with oxytocin. The following evening, due to failure to progress, I was advised that we should proceed to theatre for a trial of forceps. At this point, I was asked to sign a consent form, but I had no real understanding about the procedure being proposed or potential complications that could arise. The consent form was a piece of paper saying trial of forceps with a space underneath asking me to sign. In theatre, my consultant attempted to deliver Sam by Keelan's rotational forceps. I was unaware of the complications unfolding during delivery, but aware of a lot of pulling and what seemed to be a lot of time passing. After what seemed like an eternity, but I'm sure was probably no more than a few minutes, the anaesthetist very gently told me that they were going to put me to sleep. At this point, I knew something catastrophic was wrong, but I didn't know if it was with myself or my baby, and I felt terrified. I woke up later to the tearful faces of my family and news that I had a baby boy who'd been taken to special care baby unit. I was extremely weak and in a lot of pain and too unwell to see him at first, but the fantastic nurses brought me Polaroid pictures and updated me often. I had feelings of both joy and extreme sadness when I saw him for the first time in his incubator. But it was only really in the coming days that I had learned what happened. During Sam's birth, his head was delivered using forceps, but his shoulders became stuck for a period of 12 minutes. I later found out that this serious obstetric complication is called shoulder dystocia. Several last resort measures to deliver him had been unsuccessful, including attempts to break his clavicles in order to fold his shoulders and to deliver him. An attempt was then made to push his head back inside in order then to deliver him by caesarean section. I have no doubt that more damage was sustained to the fetal head at this stage. When that failed, finally 2 attempts were made to split my cartilage, my pelvic cartilage or bone, but a scalpel blade detached on both occasions. My consultant said, although it was not completely successful, it created enough leeway for her, and with one final surge of adrenaline on her part, she pulled hard on his left arm and finally freed him. Next slide, please. He was eventually stillborn, requiring CPR and adrenaline to restore his heartbeat. I was told he was likely deprived of oxygen for most, if not all, of that time. Sam spent a difficult 6 weeks in special care baby unit. He initially had his lungs ventilated, suffered with seizures due to hypoxic encephalopathy, and had trauma to his head and neck with subdural hematomas. He was immediately diagnosed with a left-sided Erb's palsy because during his convulsions he did not move that arm. That was the arm that she pulled on with force. And at 3 months of age, he was diagnosed with cerebral palsy. Needless to say, I was also in a poor way, both physically and mentally. But I thank God every day that we both survived. And trying to put a positive spin on it, I look back now and think maybe it was to tell our story and to change the future of patient safety. So despite a very basic explanation of events by my consultant obstetrician, no answers have been given as to why this had happened and if it could have been predicted or prevented. It was my sister through her training in anaesthetics, which included that doctors have a duty to fully consent patients, discuss options and inform them of significant risks, that supported me towards finding answers about why this hadn't happened in my situation. We researched what the risk of shoulder dystocia in my situation might have been. After looking through GMC and obstetric college guidelines, as well as many other scientific papers on the subject, it became clear that my care with regards to explanation of risks, options for my delivery, and informed consent had been well below standard. Next slide, please. Through our research, we discovered that I had a high risk of shoulder dystocia with the risk factor of type 1 diabetes alone in the region of 9 to 10%. And that risk was further increased by my short stature and my known macrosomic baby. Moreover, the prolonged labour and instrumental delivery increased this risk further. I was furious that this had not been discussed with me antenatally, despite my repeated requests. Why had this vital information been withheld from me? If I had known about the high risk, I would have opted for an elective caesarean section and Sam would have been born unharmed. I felt that I had not been given the information I was entitled to, nor allowed to be a partner in the decision-making process with regards to the care and delivery of my child. It did not seem right that decisions were being made for me, but without me. After all, it's Sam and I that live with the consequences of those decisions, and we still do 25 years on. So what did we do? Well, we composed an initial complaint letter to the Trust, which asked, amongst other things, why I hadn't been informed of the risks or options for delivery, including caesarean section. We were met with an uninterested generic reply along the lines of, we have conducted our own internal investigation and we're sorry for the sad outcome. However, we feel that the care you were given was adequate. I never really understood the concept of a hospital trust investigating itself. To me, it's a bit like marking your own exam paper. So this dismissive reply upset me greatly, as it appeared as though no one cared or even recognised that there was a deficiency in my care. And my concern was that if people didn't recognise that, then no positive changes would be made. And if no positive changes were going to be made, then it surely follows that this would happen again. So it became my goal to ensure that others didn't go through what I did, and the right discussions should be taking place regarding options and risks between doctors and patients, allowing the patient to make an informed decision with the support of their doctor. And this is why I'm a strong advocate for the term supported decision making and not shared decision making, putting the patient firmly at the centre of the decision making process. Shared decision implies a joint decision, and I put forward that a better, more apt phrase would be supported decision making. This recognises the role of the doctor correctly, as their duty is only to support the patient in making their decision. With continued use of the term shared decision making, we will prolong the distortion of the important values that underpin the principle of autonomy and may never fully let go of paternalism. So Sam growing up needed a lot of input. He was diagnosed with a dyskinetic type of cerebral palsy at 3 months of age, so he required physiotherapy. speech therapy, occupational therapy, hydrotherapy. He also required additional physiotherapy for his left-sided Erb's palsy. Thankfully, I have an amazing family who all helped me, and my mum took early retirement from her job as a GP to help. Sam has had so many difficulties growing up socially and obviously physically as well. His speech was poor, he walked with difficulty and required calipers, and on top of that, he had difficulty with two-handed tasks because of his Erb's palsy. He's super intelligent, and this sometimes makes it harder for him because he gets so frustrated. He's now 25. He graduated a few years ago from university with an honours degree in software engineering. He required full-time carer to get from class to class and to help him scribe because he couldn't write. He has little awareness of dangers. He requires a lot of observation as well. I'm so proud of all the obstacles that he's overcome, but I'm sad because when I look back, I realise this was so preventable and it didn't need to happen. What was the point of me attending the joint diabetic obstetric clinic? What was the point of the serial fortnightly ultrasounds if the outcome was always going to be the same for me? Next slide, please. So unsatisfied with the response from the trust, I went to see my lawyer when I was old enough after Sam's birth and well enough. Our case came before the Scottish Outer House in 2010 at the Court of Session, which is our civil court here in Scotland. And then we appealed to the Extra Division of the Inner House in 2013, where they upheld the legal principles set out in our UK case law from over 30 years earlier from Siddeley and Bolam, that doctors should be assessed by their peers as to which risks should be disclosed to the patient. I argued that my doctor had breached her legal duty by not explaining significant risks that could arise during the delivery of my child, more specifically the 9 to 10% risk associated with the obstetric emergency of shoulder dystocia. I claimed that I ought to have been warned of the substantial risk and that the risk could have been avoided altogether by caesarean section, which was a reasonable alternative. Furthermore, I argued that when matters of consent are considered, it is no longer acceptable and appropriate to use the established standard of accepted body of responsible opinion within the medical profession. The courts accepted that the 9 to 10% risk was high, but focused more on out of that 9 to 10% risk of shoulder dystocia, there was only a small further risk, 0.1%, of grave harm. The whole point of shoulder dystocia is that until you're faced with that issue, you cannot know or predict easily which one will be resolved. No doctor can know in advance which shoulder dystocia is going to be severe until it happens. I was devastated at these outcomes, but I refused to give up. During this time, I became fascinated with medical ethics, and I completed my law degree and started my master's in informed consent, or valid patient consent. Next slide, please. In 2014, I took my case to the Supreme Court in London, where they assembled a full bench of 7 judges, which gave us an indication that they were finally taking the matter very seriously, as they only usually do that when they're considering a change in law. You may have seen that from news such as Brexit. The GMC also spoke at the appeal, intervening, highlighting the good medical practice guidelines from the era of Sam's birth and emphasised the need for doctors and patients to be making decisions together. Because at this point, prior to the decision in Montgomery, the UK law did not reflect the professional GMC guidance, which led to a confusing situation where some doctors respected the rights of patients and complied with the regulatory body, and some doctors did not. The doctors who did not comply and refused to uphold the rights of patients were paradoxically protected by the courts by an accepted body of responsible opinion who also did not comply with their regulatory body. On that basis, justice was unfairly denied to many patients. Furthermore, by the courts endorsing this unfair practice, it appeared that the law was in fact preventing healthcare professionals from learning from their mistakes. NHS Resolutions in England recently conducted research into why patients bring forward claims of negligence and what factors need to be present. 93% of claimants were motivated by frustration and how their complaint was handled and simply wished for an apology or to ensure prevention of similar mistakes happening again. It's interesting to consider that if the majority of injured patients wish to prevent similar mistakes recurring, but cases were dismissed because the body of opinion was found to support the mistake, then how could patient care ever develop? So in 2015, all 7 judges unanimously agreed with me, and the ethical guidance with respect to informed consent that was already really essential for doctors was now passed into law. The Supreme Court held that decisions in relation to information disclosure will be determined by the courts, not by medical experts, which consequently shifts the standard from the reasonable doctor to the reasonable, or indeed unreasonable as the case may be, patient. My doctor was found negligent in that she failed to give me the information I needed regarding risks and options for delivery to allow me to make an informed decision. Next slide, please. Lord Reid, one of the Scottish judges who is now President of the Supreme Court, stated, "The doctor is therefore under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in any recommended treatment and of any reasonable alternative. The test of materiality is whether, in the circumstances of the particular case, a reasonable person in the patient's position would be likely to attach significance to the risk, or the doctor is or should reasonably be aware that the particular patient would be likely to attach significance to it." The Supreme Court added, "With the advent of the Human Rights Act, patients are now to be viewed as persons holding rights rather than the passive recipients of the care of the medical profession. Times have changed with the advent of the internet and so many other sources of information available to patients, such as support groups." Next slide, please. But the words that meant the most to me were the words that came from Lady Hale. She read out a quote from my consultant's evidence when asked why she didn't offer a caesarean section. And she said, "It's not in maternal interest for women to have caesarean sections." Lady Hale emphasised that whatever my consultant had in mind, it did not look like a purely medical judgment. It looked like a judgment that a vaginal delivery is in some way morally preferable to a caesarean section. And this is exactly how I felt. She managed to say so eloquently what I couldn't put into words myself during the trial. It shouldn't matter how a patient wishes to deliver her baby, if she wishes to give birth at home, or in a hospital, or in the woods, whatever floats her boat. All that should matter is that she knows the options, she knows the risks of each option, and she makes her informed decision with the support of her doctor. And this applies throughout all healthcare, not just obstetrics. So following the Supreme Court decision, valid patient consent is now essential for medical professionals, thus protecting the rights of individual patients, leaving medical paternalism far behind. Although it would be delusional to suggest that the decision has ended paternalism, in reality it certainly has made significant inroads towards that. The decision also finally caught up with the GMC guidance on consent, and I wholeheartedly agree with the argument that the judgment simply reflected good ethical practice detailed in their guidance that doctors were already familiar with. Competent doctors were already abiding by the GMC standards on consent as early as the 1990s. So today, where questions regarding breach of duty on information disclosure cases come before the courts, the new standard will be applied based on the evidence accepted by the judge on a balance of probabilities. A simple signature on a consent form does not prove that a conversation has taken place and is not sufficient evidence in a court of law in this regard. It merely provides that the patient has agreed to a procedure, but tells us nothing about whether conversations about risks, benefits, and alternatives have been discussed in order to facilitate a valid and legal free choice. So despite the unfortunate events we went through, the NHS is an amazing institution with doctors delivering excellent and high quality care around the clock. And I know that from my care with diabetes and my son's care, looking after his cerebral palsy growing up. It's so heartening to see that many great initiatives are now going on in the UK, emphasising the importance of understanding what's important to the patient and allowing them to be partners in decisions affecting their lives. From the I Decide Consent Tool initiative to realistic medicine in Scotland. The rights of the patient will now need to be heard and respected, with patients making their own informed decisions together with the support of their doctor. After all, It is the patient, not the doctor, that has to live with the consequences of those decisions, and they have to for the rest of their lives. Thank you.